Atrioventricular canal defects represent a spectrum of malformations involving the central portion of the heart. In the complete form, there is a single common atrioventricular valve bridging both ventricles. In the incomplete form, there are two separate valves, but the mitral valve has a cleft. These lesions are strongly associated with trisomy 21, accounting for nearly half of all cases. Recognizing that association is important because any newborn with Down syndrome should be carefully evaluated for an atrioventricular canal defect. The physiology combines both atrial and ventricular level shunting. Blood flows left to right across the atrial and ventricular septal defects, creating significant volume overload of the right ventricle and pulmonary circulation. The result is early congestive heart failure, often emerging around 2 to 3 months of age when pulmonary vascular resistance has fallen. These infants are also at high risk for rapid development of pulmonary vascular disease, much earlier than with isolated VSDS or ASDS. Without timely surgical correction, irreversible changes can occur, making repair more complex and long-term outcomes worse. Understanding this physiology explains why atrioventricular canal defects require earlier recognition and surgical referral than many other shunt lesions. Management of atrioventricular canal defects begins with stabilizing the infant medically. Congestive heart failure is treated with diuretics to reduce volume overload, ACE inhibitors to lower afterload and improve forward flow, and careful nutritional support to maintain growth despite high metabolic demand. Definitive therapy is surgical, typically performed between 6 and 12 months of age. The standard repair uses a two-patch technique to close both the atrial and ventricular components of the defect, along with reconstruction of the atrioventricular valve to restore competent leaflet function. The critical goal is to operate before pulmonary vascular resistance rises permanently. These infants are uniquely vulnerable to early pulmonary vascular disease, especially those with complete canal defects. Children with Down syndrome deserve particular attention because their pulmonary vascular resistance may fall earlier and more dramatically, leading to faster progression of pulmonary hypertension. Timely recognition, effective medical stabilization, and appropriately timed surgery together prevent irreversible vascular changes and give these infants the best chance for long-term survival with preserved ventricular and valve function. Coarctation of the aorta is a narrowing of the vessel that most often occurs at the aortic isthmus, just beyond the origin of the left subclavian artery. There are two anatomic forms. The discrete type appears as a sharp, shelf-like narrowing, while the long segment form reflects tubular hypoplasia of the arch. Associated cardiac lesions are common and clinically important. Half of affected infants have a bicuspid aortic valve. Mitral valve abnormalities and ventricular septal defects are also frequently seen, so coarctation is rarely an isolated finding. The hallmark of diagnosis is a pressure gradient between the upper and lower extremities. A difference greater than 20 millimeters of mercury strongly suggests coarctation. In practice, this is assessed with 4 extremity blood pressures, ideally measured simultaneously when possible, along with pulse evaluation for diminished femoral flow. Recognizing the anatomic patterns and associated lesions is essential for surgical planning, but even at the bedside, appreciating the significance of a blood pressure gradient ensures this critical lesion is not overlooked in a neonate presenting with shock or differential cyanosis. Critical coarctation of the aorta often declares itself dramatically in the first week of life. While the ductus arteriosus is open, systemic perfusion is partially supported. Once it constricts between 2 and 7 days of age, the narrowed aorta is unmasked and systemic output collapses. The presentation can mimic sepsis with poor perfusion, lethargy, and metabolic acidosis. What distinguishes it are differential pulses, strong brachial pulses, but weak or absent femoral pulses. Renal dysfunction may be one of the earliest laboratory clues, as the kidneys lose blood flow distal to the narrowing. Emergency management hinges on reopening the ductus with prostaglandin E1 infusion. Restoring ductal flow rapidly improves systemic perfusion. Inotropic support may also be required if ventricular function has deteriorated from afterload stress. The immediate goal is not definitive repair, but stabilization. Surgery or catheter-based intervention is best undertaken after circulation and end organ function have been optimized. Recognizing this emergency presentation and initiating prostaglandin quickly can be life-saving. Long-term management of coarctation extends well beyond the initial repair. Several surgical techniques are available, including end-to-end anastomosis, subclavian flap repair, and patch aortoplasty. The choice depends on the anatomy and the age of the patient, but all aim to restore normal aortic caliber and flow. Recoarctation occurs in 10 to 20% of cases, with the highest risk in neonates because the aortic tissue is small and prone to scarring as it heals. Balloon angioplasty is now widely accepted for recoarctation, though it is less favored as a primary repair in neonates due to higher recurrence rates and risk of aneurysm formation. Even with successful repair, long-term complications are common. Persistent hypertension is seen in many patients, reflecting vascular remodeling and increased stiffness of the aortic wall. In addition, associated bicuspid aortic valves may progress over time, leading to stenosis or regurgitation that requires surveillance. Because of these risks, lifelong monitoring is essential. This includes routine blood pressure checks in all extremities, periodic imaging of the aorta, and counseling about safe levels of physical activity. Coarctation is therefore not a condition that ends with surgery, but one that requires ongoing follow-up into adulthood. The 5 T's are a useful way to remember the major cyanotic congenital heart diseases. Each presents with right-to-left shunting, but the mechanisms differ. Transposition of the great arteries is the most common cyanotic lesion in the newborn period. The aorta arises from the right ventricle and the pulmonary artery from the left ventricle, creating parallel rather than series circulation. Survival depends on mixing at the atrial, ventricular, or ductal level. Tetralogy of Fallot is the most common cyanotic defect overall. Its 4 components are ventricular septal defect, overriding aorta, right ventricular outflow tract obstruction, and right ventricular hypertrophy. The degree of outflow obstruction determines the severity of cyanosis. Tricuspid atrasia eliminates the right atrioventricular connection, producing single ventricle physiology. Blood must cross an atrial communication to reach the left side, and systemic venous return then passes through the left ventricle and a VSD or PDA to the lungs. Truncus arteriosus results when a single arterial trunk supplies both systemic and pulmonary circulations. It is strongly associated with 22q11.2 deletion, so genetic testing is recommended when this lesion is identified. Total anomalous pulmonary venous return is unique because pulmonary veins connect to the systemic venous circulation rather than the left atrium. If the venous pathway is obstructed, it is a surgical emergency because severe pulmonary edema and profound cyanosis develop quickly. Together, these 5 lesions cover the majority of cyanotic heart disease encountered in the NICU and should always be front of mind when evaluating a cyanotic newborn. Truncus arteriosus is a rare but important lesion where a single large vessel arises from the heart, giving rise to the aorta, pulmonary arteries, and coronary arteries. This anatomy reflects a failure of normal outflow tract septation during development. It carries a strong association with 22q11.2 deletion syndrome, also known as DiGeorge syndrome, so genetic testing is often recommended once the diagnosis is made. The physiology creates both volume and pressure overload of the ventricles. Because systemic and pulmonary circulations share the same great vessel, blood mixes completely, and both ventricles pump against systemic resistance. Pulmonary blood flow is usually excessive, and as pulmonary vascular resistance falls in the first weeks of life, congestive heart failure develops early, often around 6 to 8 weeks. Clinically, infants may show only mild cyanosis initially, but tachypnea, poor feeding, and hepatomegaly soon emerge as signs of heart failure. Surgical repair is required within the first year, typically by 6 to 12 months. The operation separates pulmonary arteries from the truncal vessel and connects them to the right ventricle with a conduit while closing the ventricular septal defect. Early repair is essential to prevent irreversible pulmonary vascular disease. In transposition of the great arteries, the normal ventricular connections are reversed. The aorta arises from the right ventricle and the pulmonary artery from the left ventricle. This creates 2 parallel circuits rather than a series circulation. Without a way for blood to mix, oxygenated blood simply recirculates to the lungs, while systemic venous blood continues through the body unoxygenated. Survival therefore depends entirely on mixing at the atrial level through a foramen ovale, at the ventricular level through a VSD, or through a patent ductus arteriosus. As the ductus begins to close in the hours after birth, profound cyanosis appears, often refractory to oxygen therapy. A classic radiographic clue is the egg on a string appearance on chest X-ray, which reflects a narrow mediastinum and enlarged globular cardiac silhouette. Emergency management focuses on restoring and maintaining mixing. Prostaglandin E1 is given to keep the ductus arteriosus open, and if atrial-level communication is inadequate, a balloon atrial septostomy is performed to create or enlarge the atrial connection. These steps stabilize the infant until definitive surgical repair, usually an arterial switch operation, can be performed. Management of transposition of the great arteries begins with stabilizing circulation. The immediate step is to maintain ductal patency using prostaglandin E1, ensuring some degree of mixing between systemic and pulmonary blood. If this is not sufficient, a balloon atrial septostomy, also known as the Rashkin procedure, is performed to enlarge the atrial communication and allow more effective mixing. This intervention can be life-saving in the first days of life. Definitive treatment is surgical. The arterial switch operation is the preferred repair, in which the aorta and pulmonary artery are reconnected to their correct ventricles and the coronary arteries are reimplanted. Timing is critical. The left ventricle must still be conditioned to pump against systemic pressure, so surgery is ideally done within the first weeks of life before ventricular regression occurs. Outcomes are excellent. With current surgical techniques, more than 95% of infants survive long-term with good functional status. This makes transposition one of the cyanotic lesions where early recognition and prompt management translate into consistently strong results. Tricuspid atresia is defined by complete absence or imperforation of the tricuspid valve, which blocks direct flow from the right atrium into the right ventricle. As a result, these infants function with single ventricle physiology, the left ventricle carrying the systemic workload. Because blood cannot cross normally into the right ventricle, an atrial-level communication such as a patent foramen oval or ASD is essential. This creates an obligatory right-to-left shunt that allows systemic venous blood to reach the left atrium and systemic circulation. Pulmonary blood flow then depends on either a ventricular septal defect or a patent ductus arteriosus. Clinically, cyanosis is present from birth, though severity depends on the balance of pulmonary blood flow. Too little flow produces profound cyanosis, while excessive flow may cause heart failure. A classic electrocardiographic clue is left axis deviation, which is highly characteristic in neonates with this lesion. Definitive management follows the single ventricle pathway. Staged Fontan palliation is performed over several years, beginning with procedures to ensure stable pulmonary blood flow in infancy and culminating in total cavopulmonary connection. Tetralogy of Fallot is defined by 4 anatomic components: a ventricular septal defect, an overriding aorta that straddles the septum, right ventricular outflow tract obstruction, and right ventricular hypertrophy that develops secondarily from pressure overload. The physiology is shaped by the degree of obstruction at the right ventricular outflow tract. When the obstruction is significant, blood preferentially crosses the VSD into the aorta, creating a right-to-left shunt and systemic cyanosis. If the obstruction is mild, blood flows left to right across the VSD, producing pulmonary overcirculation rather than cyanosis. This explains the clinical spectrum. Infants with minimal obstruction, sometimes called pink tets, may appear well early and present only with a murmur. At the other end, severe obstruction produces cyanosis from birth and sets the stage for hypercyanotic or TET spells. Understanding how the balance of pressures across the VSD determines the direction of shunt is the key to predicting presentation. It also explains why the same anatomic defect can look very different from one infant to another. Hypercyanotic spells, often called TET spells, are acute emergencies in tetralogy of Fallot. They occur when right ventricular outflow tract obstruction suddenly worsens, often from infundibular muscle spasm, while systemic vascular resistance falls. This combination drives more blood through the VSD into the aorta rather than into the lungs, sharply increasing right-to-left shunting. Common triggers include agitation, crying, or defecation, all of which raise catecholamines and dynamic obstruction. Clinically, the infant develops sudden worsening cyanosis, rapid breathing, and sometimes irritability or lethargy. Without intervention, cerebral hypoxemia may lead to seizures, stroke, or even death. Older children sometimes squat instinctively during a spell. This maneuver raises systemic vascular resistance, reduces the right to left shunt, and improves oxygen delivery. Recognizing the physiology behind these spells is critical. They are not just brief cyanotic episodes, but a true medical emergency requiring immediate action to restore pulmonary blood flow and systemic oxygenation. Management of a hypercyanotic spell is aimed at reversing the physiology, driving the right to left shunt. The first maneuver is placing the infant in the knee-chest position. This increases systemic vascular resistance, reducing right to left flow across the VSD and pushing more blood into the pulmonary circuit. Supplemental oxygen is given, though its effect is modest since the primary issue is shunting rather than ventilation. An intravenous fluid bolus can help by increasing preload and right ventricular output. Medications target both irritability and vascular tone. Morphine calms the infant, reduces catecholamine surge, and helps relax the infundibular spasm. Phenylephrine is a direct vasoconstrictor that raises systemic vascular resistance, further limiting shunting. Propranolol is effective in reducing dynamic infundibular obstruction and preventing recurrent spells. If medical therapy fails, emergency surgical or catheter-based intervention becomes necessary to relieve the obstruction or provide a stable source of pulmonary blood flow. This stepwise protocol highlights the urgency of TET spells. They represent a physiologic crisis that, if uncorrected, can lead rapidly to hypoxic injury or death. Surgical management of tetralogy of Fallot focuses on two main goals: closing the ventricular septal defect and relieving the right ventricular outflow tract obstruction. This restores normal series circulation and eliminates the right to left shunt that causes cyanosis. Timing of complete repair is usually between 6 and 12 months of age, but surgery may be performed earlier if the infant is profoundly cyanotic or has recurrent TET spells. When immediate full repair is not feasible, a staged approach may be used. The most common option is a modified Blalock-Taussig shunt, which provides reliable pulmonary blood flow until the child is stable enough for complete repair. Long-term, most children do very well, but there are predictable complications. Pulmonary regurgitation is common after relief of outflow obstruction and can lead to right ventricular dilation over time. Arrhythmias may also develop, particularly in those with large ventriculotomy scars. Some patients eventually require pulmonary valve replacement in adolescence or adulthood. Despite these challenges, outcomes are excellent. More than 90% of patients achieve long-term survival, many with good functional status. The key is recognizing that lifelong follow-up is required even after a technically successful repair. Hypoplastic left heart syndrome is one of the most severe congenital heart defects. The left-sided structures, including the mitral valve, aortic valve, left ventricle, and aortic arch, are markedly underdeveloped. This leaves the right ventricle as the only effective pumping chamber. Pathophysiology is centered on ductal dependence. The right ventricle must support both pulmonary and systemic circulation, and systemic blood flow is delivered retrograde through the ductus arteriosus into the aorta. If the ductus constricts, systemic perfusion collapses. Clinically, infants appear stable at birth, while the ductus is open but progress to shock within hours to days as it closes. A striking finding can be differential cyanosis. The lower body may appear pink because it receives better mixed blood from the ductus, while the upper body remains cyanotic due to desaturated blood from the right atrium crossing the foramen ovale and filling the ascending aorta. Adequate atrial level mixing is another critical factor. Without free flow across the atrial septum, pulmonary venous blood cannot reach the systemic circulation. Inadequate mixing leads to profound hypoxemia and requires urgent atrial septostomy. Understanding this physiology highlights why prompt recognition and initiation of prostaglandin therapy to maintain ductal patency are life-saving, while surgical or transplant strategies are planned. Management of hypoplastic left heart syndrome relies on staged surgical palliation to reconfigure circulation so that a single right ventricle can support the body long-term. Stage 1, the Norwood procedure, is performed in the neonatal period. The goal is to create an unobstructed systemic outflow by reconstructing the aortic arch and to provide controlled pulmonary blood flow, usually through a shunt. This stage carries the highest risk, with mortality of 10 to 20%, even in experienced centers. Stage 2, the Glenn procedure, is performed around 4 to 6 months of age. The superior vena cava is connected directly to the pulmonary arteries, so venous return from the upper body flows passively into the lungs. This reduces the volume load on the single ventricle. Stage 3, the Fontan operation, is done between 2 and 4 years of age. Here, the inferior vena cava is also connected to the pulmonary arteries, creating a total cava-pulmonary connection. At this point, the systemic and pulmonary circulations are completely separated, with the right ventricle serving as the systemic pump. The overall strategy is to create stable physiology from a single ventricle circulation. While outcomes have improved markedly, the Norwood remains the most challenging stage and requires meticulous perioperative management to optimize survival. Medical management of hypoplastic left heart syndrome is focused on stabilizing physiology until surgical palliation can be performed. The single right ventricle must supply both circulations, and balance between pulmonary and systemic flow is critical. Prostaglandin E1 is essential to maintain ductal patency, since systemic blood flow depends on the ductus arteriosus. Oxygen must be used carefully. High-inspired oxygen lowers pulmonary vascular resistance, which can steal blood from the systemic circulation. For this reason, target saturations are intentionally lower, typically 75 to 85%, which corresponds to a balanced QP to Qs ratio near 1 to 1. Ventilation strategy supports this balance. Allowing mild hypercapnia and relative hypoxia helps maintain pulmonary vascular resistance high enough to prevent excessive pulmonary runoff. Excessive inotropic support should be avoided, as it may increase oxygen consumption and worsen the imbalance. Similarly, hyperventilation drives down CO2 and pulmonary vascular resistance, again favoring pulmonary over systemic flow. Every aspect of management is directed at protecting systemic perfusion while awaiting surgery, highlighting how different the goals are compared to typical critical care. Medical management of hypoplastic left heart syndrome is focused on stabilizing physiology until surgical palliation can be performed. The single right ventricle must supply both circulations, and balance between pulmonary and systemic flow is critical. Prostaglandin E1 is essential to maintain ductal patency, since systemic blood flow depends on the ductus arteriosus. Oxygen must be used carefully. High-inspired oxygen lowers pulmonary vascular resistance, which can steal blood from the systemic circulation. For this reason, target saturations are intentionally lower, typically 75 to 85%, which corresponds to a balanced QP to Qs ratio near 1 to 1. Ventilation strategy supports this balance. Allowing mild hypercapnia and relative hypoxia helps maintain pulmonary vascular resistance high enough to prevent excessive pulmonary runoff. Excessive inotropic support should be avoided, as it may increase oxygen consumption and worsen the imbalance. Similarly, hyperventilation drives down CO2 and pulmonary vascular resistance, again favoring pulmonary over systemic flow. Every aspect of management is directed at protecting systemic perfusion while awaiting surgery, highlighting how different the goals are compared to typical critical care. Clinical presentation of total anomalous pulmonary venous return depends heavily on whether venous drainage is obstructed. In unobstructed cases, infants often show only mild cyanosis initially. Over weeks to months, volume overload of the right heart produces congestive heart failure with tachypnea, poor feeding, and hepatomegaly. A classic chest X-ray finding is the snowman, or figure 8 silhouette, most often seen with supracardiac TAPVR. Obstructed TAPVR is a true surgical emergency. From birth, these infants develop severe cyanosis and respiratory distress that does not improve with oxygen because pulmonary venous return is trapped and congested. Pulmonary edema appears rapidly, and without immediate surgical relief, cardiovascular collapse can follow. On physical exam, common findings include a fixed split-second heart sound from chronic right heart volume load, a systolic murmur caused by increased flow across the pulmonary valve, and sometimes a diastolic rumble from high flow across the tricuspid valve. Echocardiography is the first-line diagnostic test, though the abnormal venous connections can be difficult to visualize. CT or MRI provides excellent anatomic definition and is often used for surgical planning. For obstructed TAPVR, the only management is emergent surgical repair to establish direct pulmonary venous connection to the left atrium.